Hey, I'm Dave. I'm going to talk for just a couple minutes about atropine sulfate. Now, atropine sulfate classification is a parasympatholytic. It's also an anticholinergic. Now, remember, parasympathetic side of the nervous system is responsible for slow and low things, right? So we're going to block that side of the house, hopefully, to pick our heart rate up if that's the reason we're giving this medication. Acetylcholine is the primary neurotransmitter for the parasympathetic side of the nervous system. We're going to block how that's absorbed as well. Now, we do decrease vagal tone, and by doing decrease in vagal tone with this medication, we should and we hope to see an increase in heart rate. We also might get some bronchodilation and some decrease in some GI secretions. It typically takes, peak effect is around 15 minutes for this to really have its full effect. When I'm going to give this medication, atropine sulfate, I'm going to give it to my unstable bradycardic patients. So I've got these bradyrhythms, altered mental status, hypotension, ischemic chest pain, signs and symptoms of shock, acute heart failure. This is going to hopefully help bring that heart rate up. I can also give atropine for organophosphate poisoning, nerve agent poisonings, or other cholinergic type of poisonings. I don't want to give this if a patient has a known hypersensitivity. Now, not many people have had atropine in their lifetime. This might be the first time they're ever having it, so it's really important for us to be really solid on our sample history before we give our medication, and to do continual vital signs and monitoring the patient when we give it. There's some dysrhythmias that when we enhance, if a medication enhances conduction, we might have an increase of a ventricular rate, rhythms like atrial fibrillation or aflutter. As far as the adverse effects, excessive doses can cause some coordination problems, a little bit of restlessness, possibly some disorientation, maybe some tachycardia. We went to the higher extreme of what we were trying to treat when we gave this to our bradycardic patients. And remember, it is an anticholinergic, so it is going to dry things out. We might have some dry mucous membranes as well. The dose of this medication, when we give it for our unstable bradycardias, we're going to give 1 milligram. It's packaged 1 milligram in 10 milliliters. This is a pretty standard setup here. Just going to kind of connect this. It's going to be IV or IO. That's going to be the route that we administer this medication. 1 milligram every 5 minutes. I can repeat this to a total of 3 milligrams. After 3 milligrams, I have complete vagal blockade, and we've kind of suppressed that vagus nerve. So if 3 didn't do the trick, 5's not going to do the trick. So we're going to stop with the adults after 3 milligrams. When we give it for organophosphate poisonings for the adults, 1 to 3 milligrams. Again, we can repeat that. And a pediatric dose, again, unstable bradycardic patients, this is going to be a second-line medication after epinephrine. We'll talk more about that with pediatrics, but the pediatric cardiac dose is 0.02 milligrams per kilogram.